I hope I've been given a great yard slot, so I hope you guys don't sleep. Thank you so much for Knowlex for inviting me to speak today. It's a topic that I'm very passionate about, those of you who know me. So I'll get started. Okay, so SSI is one of the biggest threats to the delivery of safe surgery. It's the second most frequent healthcare-associated infection, both in Europe and in the USA. It can have devastating effects on the patients, and of course it costs quite a lot of money to treat. We do know that certain amounts of SSI are preventable, and we've got like nice quality statement, statement 49, which gives us guidance on what we can do to reduce SSI. And on that quality statement, standard 7 talks about surveillance. So surveillance is a key component to quality standards. So, and from now on, we'll be talking obviously about the surveillance that we do at Public Health England. So the surveillance started back in 1997, and it's started to provide a mechanism for hospitals to be able to collect data and use that data to improve patient care. At the moment, we've got approximately 371 hospitals in England registered to participate. There's a mixture of NHS hospital and independent sector. For independent sector, there's a new competition market order, which means that independent sector hospitals will have to be doing more surveillance. So we're likely to see increases in the amount of participation within that sector. We currently offer 17 categories of surgery. Orthopedics, as many of you know, is mandatory, and other categories are voluntary. The only data that is published would be the mandatory data. And we process over 150,000 records per year. And it's one of the most comprehensive surveillance in Europe. So let's talk a bit about case ascertainment then. So it's meant to be systematic prospective monitoring of patients. So, and that does from the time the patient has the surgery up to 30 days of surveillance follow-up you do. If the patient has an implant, then that will continue for up to a year. And that is not active follow-up for up to a year, but it means that if your patient should be readmitted into a hospital, that you should have systems in place to detect those patients who are readmitted. So our forms of case ascertainment, obviously your inpatient surveillance, your post-discharge surveillance, including hospital readmission that I spoke about earlier on, outpatient community, if you're detecting patients who come back to your clinics or seen in A&E or by community midwife or so on. And of course we have patient questionnaire. So the case definitions are the same that are used for the Centers for Disease Control and for ECDC as well, which is the European Centre for Disease Control. We use the same definitions as they use. And that would include superficial, deep, and organ-based infections. And I know there's been discussion about whether or not superficial infections should be included. And for our surveillance, yes, we do want you to include all superficial deep incision. As I say, a superficial of today could be your deep or your organ space of tomorrow. And for the patients suffer, so we would expect that all these would be included in the surveillance. So how do we maintain quality assurance then? Well, we provide training for hospitals who are partaking in the surveillance, they are expected to come and be trained by us. I've done an analysis of training over the last 3 years, and what we saw is that the majority of staff trained from the hospital were nurses, and that were a combination of infection control, surveillance staff, or ward staff also, and some theatre staff. We would obviously like to see more of the surgical team trained, because surveillance is about multidisciplinary approach. So if you're working together and you all have the same understanding of what is expected of you, then of course you would have better results and better engagement. So there is the program that you can see there. Let's see the pointer. So this is the program. It's a full program. We look at the introduction, the methodology, definitions of SSI, and how to interpret the data also. And there are practical sessions so that hospitals become familiar with what is expected of them. We also provide continuous support. So the SSI team, you can call us. For those of you, I know quite a few of you in the audience or that I know participate in the surveillance. So you have the opportunity, you can call us at any time. We will answer any data query, whether it's on coding, inclusion, exclusion criteria, and of course SSI definitions. Part of the quality assurance also is that we validate the data. So your data will be validated using electronically or manually by our staff, which we consider as experts. And they look for missing values, unusual values, or non-compatibility. So it may be that you selected a cemented OPCS code, however, there's a tick box where you've put no cement used, so that's the incompatibility. So all of this, we would, if we see any of these missing values or unusual values and so on, then the surveillance staff will contact you to query this. And the hospital can download from our user-defined report, they can monitor their own data quality. And you can see I've printed out, I've actually put a report that you can see. So you can then measure your own data quality. Now, how do you interpret the results? So here we look at your benchmark. So the benchmark is the 5-year aggregated data. So it's a pool of data of the last 5 years of all participating hospitals. It includes inpatient and readmission SSI data only, and SSI detected using any other method or the other post-discharge methods are not included. And this benchmark can be applied to hospitals who are doing one surveillance period only or continuous surveillance. And this is how you would interpret your results. So this hospital had 75 procedures in large bowel surgery, and you can see they've got 11 infections, a rate of 14.7. And if you compare it to the national benchmark there's I think it's 9.8. So you can see that hospital, even if you look at data over the last 4 periods, you have larger numbers, and you still see that hospital is above the benchmark. So that hospital would receive a letter from us, an via letter. I'll go on a bit more into how do you compare your data. So there are considerations, because I often hear from hospitals about, we've looked at a different piece of research that shows that there are higher incidence of SSI compared to your national benchmark. And you have to take caution with using the data, other forms of data to make comparison. So as we often say, it's like comparing apples to pear. And you need to look at the differences in the methodology, interpretation of case definitions, whether there's high or low risk procedures included, and that's different from the surveillance that you're comparing it to, whether there are differences in compliance with guidelines and care bundles, look at the length of stay, and whether or not there are different methods of case ascertainment included. Other factors you need to look at, patient demographics, looking at healthcare, different healthcare systems it may be, and what sort of staffing they have and the support. Surveillance is not research, and we need to really get this across, that it's not research. Methods used for surveillance must be sustainable. And the national benchmark includes data from all the participating hospitals over a 5-year period. And whereas if you compare it to a study that's been done, it may be that that study just looked at data from one site or a few sites. So that must be borne in mind when you do making those sorts of comparisons. So just to talk about the outlier identification process, and just to go through the timeline, just to demonstrate that it takes a while before you can get your outlier alert, And the reason for this is that if you were doing surveillance and you started in January to do January to March, the patient who has surgery at the last day, the 31st of March, has to be followed up for 30 days. So then it then allows you time to collect that data and then to submit that data. It has to be reconciled. The reconciliation means that you're saying to us that you are sure about the numbers and the number of patients included in that cohort that is accurate, and also the number of infections are accurate at that time. The report is made available as soon as the reconciliation process is done. So if your hospital is quite quick, then you will get your report and you can then start to evaluate your report. After that, we then go on to do the outlier analysis and identification within about 2 weeks of the end of the reconciliation period, and then the alerts will be sent out. So you may be looking at between 3 to 4 months before you can get your alert. It may sound like a long time, but when you think about the processes involved, and we need to make sure that the data is accurate, and so on. However, there is a way that hospitals can decide whether or not, or establish whether or not they're likely to be high outliers. So in the summary report, if you look at the summary report, you will get a box and whisker plot as well in there. So high outlier is any hospital that has rates above the 90th percentile, and the low is below the 10th percentile. So high, your rates are high as they're concerned. Low, it may be about your methods, your methodology. So we want you to look into that to see whether or not you're actually detecting all your infections. So if we just choose, let's say, large bowel surgery here, if I can get the pointer to work properly. If you look, so a hospital, this is the 90th percentile, that's the 10th percentile. So these hospitals there, they will be considered as high outliers because they lie above the 90th percentile. And likewise, for those who lie below the 10th percentile, they'll be considered to be low outliers. So you can, if you know your rate of infection, because you've downloaded the summary report, you know the rate of infection. Say this was your hospital, and you've got about 22 infections, then you're sure that you will be getting a high outlier letter. Likewise, if you were down here, you'd be getting a low outlier letter. So the reports that we send you, the alerts, are confirmatory. It's just to say, it's, yes, we confirm that you are an outlier. But you can, as I said, be able to establish that before these letters come out to you, or these alerts. And just with low participation categories, because we do have some categories that were newly introduced and they're low participation at the moment, So we just say that, you know, we will send you a letter just to say, just look into your rates of infection, or any of these infections preventable, but you do need to, you know, take caution in interpreting those. So what do we expect when outlier alert, you know, sent out? So we expect hospitals to respond, to acknowledge that the receipt of a notification, and also to provide outline a planned investigation, including confirmation, and there is the methodology. We do provide support to hospitals. We do in-depth analysis, site visits to hospitals, or provide contact with mental hospitals. So hospitals who've managed to reduce their rate of infection or have had low infection rates, we can put hospitals together so that they can work and find out, you know, what those hospitals may be using to, you know, be able to have lower rates of infection. So what can we do? I know I've run out of time, but it's, you know, we can, what else can we do? We can audit hospitals. We can go around and do audits on hospitals, but to do your case note review. But that would be very timely, and can we achieve it given the number of hospitals we have in England? We can compare data on HES, but this will not be routinely undertaken. We have done it working with hospitals. We work in partnership, and that is based on trust. Work with commissioners, yes, we can do that. And we can make other methods of post-discharge surveillance compulsory. But we're working in a time of financial constraint, and are we able to do that? We are, however, thinking in the process of developing the electronic patient questionnaire, so that would make that process a lot easier and reduce the burden. Just some hospital experiences where, from our annual report, where we've just taken some snippets there, where hospitals have used multidisciplinary approach, innovation, working in partnership, alert, outlier alerts, and visit from us, and also where they've audited against NICE guidelines. So I leave you with a summary here that certain amounts of SSIs are preventable, and that's the reason why we're here today, to talk about this. Benchmarking is effective if you make good, meaningful, comparison, meaningful data, and you compare apples with apples. Outlier alerts are intended as trigger for further investigation. They're not served as punitive. They're there for you to look and see if there are other things that you could have done to reduce those infections. And, please bear in mind that continuous support is available from our service. We're always willing to help. Thank you.